Okay, welcome everybody to this Thursday Night Live, which is actually on a Friday afternoon where I am. And I think, is it Thursday or Friday morning where you are?
Friday night here.
Friday night. Oh, okay. It looks so bright in the window over there. Okay. You may be watching this webinar live on a Friday if you are an Airway Circle member. All non-members will view the recorded version as part of our weekly Thursday night programming at a later date. So for those who may not know me, I'm not Renata, I'm Ann Blau, speech-language pathologist and certified myofunctional therapist and editor-in-chief of Airway Circle, filling in for her. And today we have the pleasure of a presentation from Esther de Ru, who is currently in the Netherlands, so thank you very much for joining us at this late hour. Esther de Ru is a seasoned physiotherapist since 1977, with extensive experience across Europe in orthopaedic manual therapy, pediatrics, and scoliosis treatment. Certified in numerous therapies, including NeuroDevelopmental Therapy-Bobath, Vojta, and TMJ jaw therapy. Esther's passion for the orofacial regions stems from her background as a dental nurse. She developed the skin approach to elastic therapeutic taping for head, neck, and orofacial disorders, and that's abbreviated ETT-HNO. We'll add that one to our list of abbreviations, and has been sharing her expertise worldwide since 2010. Esther is also a respected contributor to international conferences and publications on this topic, and I'm sure I'm missing something, so I will let you fill this in. Let me just introduce our topic, which is elastic therapeutic taping and respiration. So welcome. Please feel free to add anything that I may have missed.
No, well, thank you very much for your kind invitation. It's the light you're seeing is actually light. It's the daylight's on my left, right, left. And that will probably be dark in half an hour. So I hope there's enough light here for you to follow. Well, thank you very much. And let's get going, because this is going to be different in the sense that, yes, we're talking about taping and respiration, but first we need to talk about the skin and how that's related to breathing. So we were fiddling around to see if everything was working a minute ago, and then I see that I didn't start. I actually have a slide open that is not the first slide, so let me get a slide. So, is skin important? Well, yes it is, and I would like to talk to you everyone in this area of breathing about the organ that has probably not been looked at that much. You will be busy with mechanics, with breathing, with the muscles, with the shape. I'm going to talk about the skin only, and how that, knowing more about that, can really enhance what you're doing. Whoops. Well, I've already been introduced. I have been around for a while, and I have actually been treating patients for a lot of decades. The wonderful thing about being a physical therapist, physiotherapist, is that I am licensed to touch, meaning I have done so my whole life, touching people. And that's when I was introduced to the elastic therapeutic tape. That made a lot of sense, because I was already using what we now call lateral skin stretch methods. And knowing more about lateral skin stretch, which can be done manually, and you actually do yourselves probably without realizing it, or maybe you do, can be really beneficial if you know a few rules. So I will be speaking about, very shortly, because I'm presuming you know probably more about that than I do, about all the muscles, and how they, every muscle related from nose to the stomach wall, but also the physiological direction of skin movement during breathing, during those muscles, and skin rules, organ zones, cutaneous nerves, the skin-brain connection, and tape as a sensory stimulus. And at the end, I will show you a few case examples. So I really liked this chapter. It's quite a large chapter. I don't know if you know it, but it's called Muscles of Breathing, the Development, Function and Patterns of Activation by Pilarski and others, and it's really relatively recent. they have looked at every muscle related to breathing and do state that roughly 20% of the 320 pairs of skeletal muscles is needed for breathing. And we all know this contraction of breathing muscles generates force and can lead to changes in the rib cage, the lungs, and the upper airways. Recruitment, timing, and intensity is adjusted automatically. Normally we don't have to think about how we are breathing and how we have to adjust our breathing to what we are doing. So in this whole chapter, of course, we can speak about muscles, and if you ask a lot of people what is the muscle for breathing, they would all say the diaphragm. And in a sense, it is a rather important one, but they define the muscles of breathing in muscles that assist lung inflation or deflation, with primary roles to expand the thorax or stabilize the thorax, and or as airflow resistance regulators. But they also divide muscles into accessory or upper airway muscles and pump muscles. They divide the muscle groups in this whole chapter into everything related to the nose, to the head neck, the thoracic, the back, and the abdominal muscles. So let me give you 2 examples and then go into the way that I work. So in the group of thoracic muscles, which are these muscles, not all of them named, but you will probably know them by heart, I think and I observe what is the skin doing when these muscles contract. So the intercostals probably help elevate all those ribs. What's the skin doing in the meantime? And how could I possibly assist the skin if I see that it's being difficult? Same with the abdominal muscles, and I've only chosen these 2 as examples for tonight, or to this presentation. The diaphragm, the obliques, the rectus, the transverse abdominis, and very interesting, the quadratus as a stomach wall muscle. Apparently 2/3 of all the cadavers have the quadratus lumborum really connected to the transverse muscle, so it is a base for our diaphragm. What happens to the skin when I use these muscles? So hopefully at the end of this presentation, you will know a lot more about how important the skin actually is. Right, a little bit more about the skin. Now, I'm not going to read this whole list because then I'd need 2 hours, but these are the properties that I'm presuming you will all know that the skin has. It protects us. It's our organ of sensation, of heat regulation, of evaporation, heat evaporation. It's also our organ of communication and aesthetics. It stores, it excretes, and it absorbs. It's water resistant, but it can, evaporation, it can have some transmission of moisture. And there is many a bacteria living on our skin. We really never want to think about that. And never mind the umbilicus in your belly button, there's even more, very exotic types. So I'm presuming you all know these properties, but let's look at the other ones. The qualities, let's call them qualities, of our cutaneous organ, because skin is an organ, our largest organ, our largest sensory organ. And thanks to the cutaneous nerves, which are actually the longest nerves when you look at them, we sense. So Diana Jacobs is a person who developed the dermo-neuromodulating method, in which she uses skin stretch to assess and treat and find problems with entrapment of nerves, but then entrapment of the cutaneous nerves. So she went back to the lab, looked at all these cadavers, and instead of cutting the skin away, which is normally always done, she searched for cutaneous nerves, found them, and has written a whole book on them. And not only has she mapped them, but she's also dived deep in to the connection of those cutaneous nerves and their function with the brain. So she is an important person in the background of the skin approach that I use when taping. Now, Desmond Tobin wrote a wonderful article, a long article, you could call it a chapter as well, calling the skin our brain on the outside. Biochemistry of the human skin, our brain on the outside. And I have experienced, seriously, the skin speaks to us. If we know how to listen, if we know how to observe and understand the reactions, we can learn a lot from the skin. So patients that cannot communicate with us can still communicate through their nervous system in the skin, and they can tell us stuff. Dr. Gimbato, I'm presuming you all know him from his wonderful video, Strolling Under the Skin, that you can still look at on YouTube. Dr. Gimbato is a plastic surgeon, reconstructive surgeon of hand problems in Paris. And he took it upon him to, during surgery, he would dive into the skin and on and under the skin to look what the whole area looked like, and shared that all with us. Wonderful. One of the videos he developed was one about skin, and he shows us, and that is quite amazing, I think, because you can actually see it in that video, is that epidermal cells change shape and volume during stretch. So the moment I stretch my skin, something happens to the shape of every cell, and that will return, every cell will return to its original state and shape after stretch. He also discovers that everything is connected to everything. It's truly, everything is connected. This epidermal cell shape change led me to realize that if I apply tape on a stretched skin, and I let go, and any tape, it could be paper tape, any type of tape, and I let go, the skin can actually not go back to its normal position. So all those mechanoreceptors must be telling the brain there's something going on down there. So that is also part of the theorizing about how does that skin work and what signals can we send to the brain through the skin. Professor Fukui, a physiotherapist who is now dean of the Tokyo University, did his PhD and looked at skin movement and the specific direction of movement of skin, the physiological direction of movement, of skin movement, and that book was only in Japanese, and then he developed a taping method called skin taping, in which he uses what he learned and developed a whole skin taping method. So what I learned from him is definitely also part of what I do. And then, have you ever realized that you can only move because your skin allows you to? And I would argue that if you, for example, give yourself, because every now and again I'm going to ask you, I might actually do that at this moment. Can you imagine that if you hold on to your stomach area, and if you're at home when you're looking at this probably, so you can do this on the skin itself, and if you first of all just sit and breathe, because you will all know how to breathe in deeply and in and out, and if you're in rest you should have a normal calm diaphragmal breathing, and only if you're really doing your best you will get some upper breathing. But now make a scar. So hold on to your tummy, bring that skin together, and try breathing again. And you will discover that you can only breathe upper. So everybody with a scar in their stomach area, you should look at the effect of that scar. And you can do that with tape, but that's another story. So let me go back to sharing. So the message is, always check for scars everywhere, not only in the body, but scars in your knee could have an effect on your breathing. It's that everything is connected to everything. Because what Dr. Gimbato has shown us, he is the only one that has done extensive research of the anatomy in living people. All the other research, the fascia research, is all from cadavers, and human cadavers that have often been embalmed. That's not the natural situation. So I prefer to listen to what Dr. Gimbert Toe says and view his work, and knowing what the others do as background knowledge, what he's telling us, I think is really important. Now, the research into something's gone wrong here. Excuse me, for some reason. I slipped a slide. Now, taping, kinesiotaping, known as kinesiology taping, and if you look around the world in literature in English, we have about 50 names for taping, because the original method was patented, so people were not allowed to use that name, kinesio. So that's why we have a lot of different taping brands, but also methods that just sound a little different, but they're all about elastic cotton tape that is elastic, that has been put to paper, and that's what we're talking about. Now, because Kenzo Kaza introduced it, and that was in the 70s, so his theories behind the taping were from the 70s, with the knowledge of the 70s. He has adapted his method, added a skin application, but sadly, a lot of the people that do research actually look at his books, and it was never actually added to his book. So that's we actually have 5 models. We have people following Kenzo Kaza's model of thought, the original one. We have the adapted one. We have people looking at taping from the fascia point of view, thinking that we are taping fascia. We have people looking at it from the energy point of view, as in if you're an acupuncturist, you will think about energy lines and acupuncture points. We have people thinking that we're taping on skin, and I happen to be one of them. And we have people that mix the models, so use a bit of this and a bit of that and a bit of, so there's all these different ideas about how tape works. One of the things in the skin brain model that I am part of is that you apply tape to skin, and you do want to know what the reaction is, so you want research. Now, all the models have had some studies conducted, but by far the most have been done on the model of the skin-brain connections. And these are all studies that I have put on a list that are mandatory for anyone who takes my taping course, because you need to know why it works. And because then you can explain to your patients, not only, and also to all these people that still think that it's all big nonsense and it's all placebo effect. So these are the names of the studies that have been conducted. And these are the research topics. So without going into any more detail, ultrasonic imaging has been used, functional MRIs. Example, an engineer who did not believe the lifting effect, or wanted to check if it was possible that skin could be lifted, put a person in an MRI and looked at their whole leg. They taped the tibialis anterior, so a muscle that lifts the foot, and he looked at the skin of the whole leg, and he found that the reactions of skin lifting were most strongest around the tape in that area, but he found skin lifting in the whole leg, and he found skin compression, because as an engineer, it didn't make sense that a body that is one closed body, covered with skin, could be lifted. It would have to have a reaction somewhere else. It's that type of study that we're looking at, and I will be giving you 2 examples of all those different studies that have been conducted. I like this study done by people from the rock tape. Of course, they conclude that rock tape is the best, but they have looked at and have realized that it's not about the brand, which is something, of course, that is often said by people selling tape. But tape is a sensory stimulus, and I completely agree. From day one, tape is a sensory stimulus. So placebo tapes don't exist. You cannot, and so all the research that has been done using placebo tapes has actually been looking at 2 types of applications. And because placebo tape doesn't exist, it's always a sensory stimulus. But the more a sensory stimulus makes sense to the brain, the more effective it will be. So this is Professor Fukui, who I met at a World Conference in Amsterdam in 2011. He was the only person who had a poster about skin movement. There were hundreds of posters, and there was his poster with skin movement. So I met him there, and we exchanged books when we both had one. I had one on the elastic taping for kids, and he had his. Mine was in Dutch. His was in Japanese. We couldn't read each other's books, but we were in contact from that day on. And he really taught me the importance of looking at skin. And he has published, he has his book, he has several publications to his name. But can you imagine when we're talking about rotation of the trunk, for example, that most physios will not be thinking of all those tiny muscles around the spine, but will be thinking the obliques and in internal, external. We are thinking in the massive muscles. But he shows us that skin actually changes in the midline, front and back with rotation, and that all you need is tiny tapes like that to activate rotation. So, and that he did that with lots of research with all these nice 3D motion analysis system testing. So I'm allowed to share his work in which we see, and it's very short, we see the effect of skin stretch, that is what we can do with tape as well, on a thigh, and it is captured with ultrasonar imaging. So I'm very glad I'm allowed to share this. It's his work, and his Japanese skin taping book comes with this video. So here we have somebody sitting, knee flexed, and they're extending their knee and relaxing their knee. So it's flexion, extension, knee. And if you look closely, you can see that there's quite a thick skin area. That's all skin. Oh yeah, sorry, you can't see my pointer. But the epidermis and the dermis is the stratified layer on top. Then we see our muscles with the white fascia layers sliding and gliding along each other. And even if you've never learned how to watch these, or you can see movement and you can guess which muscles they are that we're looking at. So he sent me this, and when I was working in Spain, I was working in an orthopaedic clinic, and I got the orthopaedic surgeon interested. So we copied. What we did was put the probe in the same place. That's me giving skin stretch. So I will be giving skin stretch, letting go, skin stretch, letting go, something that the tape also can do later. And this is then what we see. The patient is not moving now. All I'm doing is stretching the skin. If you look at the top left of that video, you will see it's going to the left and front. And I'm going to repeat this because it really is a short bit. So we have somewhere around here, we have the patient flexing their knee.
Esther, we can see your pointer. We can see your pointer. So,
so we see, and look, that's the skin. Oh, that's great. And this is us repeating this testing and or his research and finding something very similar. Me pulling the skin upward and letting go. And you would argue, yes, but that skin, that tapes on there and that's not moving. Yes, it is. So this is your skin again. And yes, it's not the same movement we're seeing. The muscles seem to go in the same direction. But what this shows is that skin stretch activates underlying muscles even at a distance. So the research of the engineer in the MRI and this type of research, quite a bit of this has been done, shows us the effect. And to answer the question that I just posed, what does that mean if I put a piece of tape there on that skin in the same area that I've been stretching? Tape doesn't move. Yes, it does. You've put tape on skin and it's partially stretched because the patient is sitting. So the skin is stretched because the knee's been bent, but it's not stretched completely because then your patient would be lying down. But your skin moves every time that lymph flow. So there's this quiet, you would say, sort of wave-like movement of skin during life. Skin moves. So even if you are not moving yourself, there's still a movement going on. So every time I imagine, because you can't research that, I imagine this tape's been put on the skin, my skin is giving these little pulses of my blood pressure or the lymph flow, and that will send receptors again, will pick that up, the mechanoreceptors, in the epidermis, because that's the only layer we're putting tape on, and it will react. So, and if, of course, if the patient moves, there'll be more. There'll be a stronger impulse, but there's still activation going on. So as soon as you put tape on your patient, you are activating muscles somewhere. So you don't want to put too much on, and you want to know what you're doing. At least I prefer to know what I'm doing. Right, now Fukui did quite some research, I was saying, and for us the really interesting one has been, first of all, only in Japanese, and thankfully it has been translated, is he looked at both Kato and he looked at what does skin do when we breathe. And yes, we can all imagine, because that is the thorax, that, as you can imagine, in style, when we breathe, we do blow up that tummy. So the diaphragmal breathing, you see that tummy expand in all directions, and especially the upper part of your body, but the whole, all the skin, if you do a deep breath, and the skin of your trunk and your stomach is one whole, and it's connected to the processus spinosi of your spine. You can move the skin of your stomach through the midline. You cannot move your skin across the midline at the back. It's stuck there. So if I'm breathing and there's more space, I will be expanding in that direction, going in the direction of the spine. So yes, but that's sort of the same direction as our ribs are going as well, except for the last bit, the upper bit. So if we're really taking a big deep breath, or we're in distress, we'll use all those accessory muscles. And they showed that the skin more or less copies what we already know the function of the rib cage and stomach is for respiration. And again, you've already felt what happens if I've got a scar right in the middle of that bit. That's a problem. That really is a problem, or can be. So let's have a feel. Again, you're probably at home and able to do this without any clothes, but let's have a feel. I would like you again to feel what your breathing is like, and not a really shallow breath. We don't need much breathing when we're sitting here doing nothing, but just take a nice deep breath and feel how you do that. And then take the top of your finger, say that bit, put it on the upper part of your sternum, transversely, yeah, and pull the skin down. And I'm going through my toes, but I can actually pull the skin down. And you don't need to push too hard. You just want to pull the skin down, and you will feel skin is not very thick on your sternum. So that's easily pulled down, but hold it there. Just hold it there. Take another deep breath. I can't use my upper airway accessory muscles now. Can you?
No.
Isn't that fun? Right, let's pull in the other direction. Same spot. And what actually happens, and especially in the people that are more upper airway breathers, they will go into upper airway breathing straight away. But if you are a normal breather and you have your skin lifted up here, you will also go into upper breathing, because my skin is telling the brain I need to do some upper breathing here. It's really connected. Again, think scars with that in the background. Now I would like you to just hold on to your rib cage, where we know that the diaphragm is somewhere below, and hold it as you would hold it when you're giving any sort of breathing manipulation. And again, think skin, don't think too much pressure, and pull the skin in the direction of the spine, which you would normally do. And you will feel that really enhances nice diaphragmal breathing and a bit of lifting. Right. Same spot, the other way around. If I let go, if I let my skin escape, yes, then I can breathe normally. But if the skin stretch is in the direction of my midline, I can't really expand here, so I go to upper breathing. So that means next time you fold your page, without knowing, you might actually, and it often depends on how you are positioned with your patient. If you're from behind, if you're from the side, be really careful, because when you're holding them like that, if you're holding them and pulling a bit to the midline, you are actually not enhancing diaphragmal breathing. So when you hold on to, experiment a bit. You might find, and in most cases it is physiological, to want to not only hold on to, but give a tiny bit of skin stretch in the direction of the spine, and you might find that that really enhances what you're already doing. And sometimes you do need to go in. I have had patients that just could not use their upper airway part. So, but that's often changed in one session. So I have used it the other way around. The same with this one. I have used it the other way around. I even sent somebody home with a piece of tape doing the same once. That was a swimmer who had completely had a very strange breathing pattern, and she just could not use that upper airway. So she had the tape on for 2-3 days, and the mechanism changed back to what is physiological, just with a bit of skin stretch. But be aware, when you apply tape and you send a patient home with tape, you must be sure that the stimulus is the right one, the physiological one. So now another interesting one is, you would think the diaphragm is, you will all know where the diaphragm is, positioned behind those lower ribs. But the interesting thing is, because as we know from the skin movement from Fukui, if, for example, you can't touch the patient here or here, you can also get them here with the stomach and pull the skin back here. Try that with the breathing. See what happens. If I pull my skin back here, and yes, I am extending and I've got external rotation, so that's also helping, but skin stretch back definitely makes it easier for me to expand my tummy. Doing it the other way, and I go up again.
So can I clarify one point? I apologize. I don't want to interrupt or
No, but this is important, so please.
So you're talking about breathing, thoracic breathing, as opposed to clavicular breathing, correct?
Clavicular breathing, I would say, is the upper airway system. And the breathing for me is both diaphragmatic, all these muscles that are helping, and the thoracic movement, but it's also the change of the pressure system. So first the diaphragm goes down, chest expands, and in rest it shouldn't be more than that, or it shouldn't even move, hardly. And then if you really need a deep breath, then you're going to use the rest. You would call that clavicular breathing. So
right. I mean, I guess clavicular would be with the movement of the shoulders as well, in a more vertical direction. So that's for like a rescue kind of breath. Do you know what I'm referring to?
That would be help. I am not getting enough air, just as throwing the head back can also be a sign
That's
of
not what you're referring to. You're referring to
I'm talking to normal breathing.
Okay.
Normal breathing. What does your skin do when you are breathing? It's trying to help you understand that we need skin, and if there is a scar somewhere and it's pulling in that direction, it might be the reason why that patient has breathing difficulties. It's more that. Yeah.
Yes, got it. Thank you.
Right. Organ zones. What on earth are organ zones? Well, they come from the Bindegeweebs massage, which is connected to tissue massage from the Mrs. Dicker and Dr. Tairich Leuber, German physiotherapist doctor, who developed this method before the Second World War, but it didn't get to the rest of Europe till after the Second World War, and it took longer to get into the English-speaking world. A method that was actually reflex therapy. Both authors actually wanted to call it autonomic nerve massage or something, but they ended up calling it connective tissue massage. What they mapped are the head zones. Head zones were specified many years ago, and doctors have been talking about head zones forever, and you could say in general that it is a collection of dermatomes. Now, they have been mapped extensively, and at the time, Head and his other people researching it would find specific skin problems or, little bumps and stuff, rashes, with people with certain internal diseases. And that's how they started spotting them, talking about them. So we know where the organ zone, the reflex zone, the dermatome related to the lungs are. And I'm allowed to use this picture from my Dutch book. This is what they look like. And so this whole area of skin is related to your lungs. And that means all that area can be used if I'm thinking a skin method. Now, organ zones, you think, what on earth are they? Well, they are palpable, visible. Sometimes they're not visible. But when you look at these people's backs, let's look at the top front lady first. You see this dent in her back, and maybe some of you have seen that. That is a bladder zone. I haven't made them completely naked, but normally we look at the naked skin. And all you need to do is look at all these skins and you will see quite some differences. And I can tell you, they're all sitting up straight because then their skin is relatively loose. And these stripes on both sides is a lung zone. So yes, through this knowledge of this method, I can even see the skin is telling me that there's something wrong with the lungs of that patient, or something has been wrong. And that has made that people who know this method also use that in relationship to using tape. There's a way of massaging, special techniques of massage to treat these organ dysfunctions if people have them. And you can do the same with tape. I would like you to have one other look, because what I haven't mentioned yet is what it says here. We've already looked at the chest breathing or the upper breathing and the diaphragmal breathing, but what happens if you sit up straight and now you need to be either stand up or sit and allow your arms to hang loosely next to your body. And again, breathe to feel what it feels like, deep breath. Then I would like you to internally rotate. Don't lift the shoulders, just internally rotate your arms as much as possible. And breathe again. And then externally rotate. And breathe again. Do you feel the difference?
I do.
Imagine all those poor people that have spasticity. They are all in internal rotation. So they are influencing their breathing just by their arm position, because the skin of your upper arm moves with breathing. And I can influence breathing through a technique on the upper arms. It's that interesting. I think it's exciting. So we can do, sometimes we can't really touch people properly. And going back to the organ zones for a minute, you will probably have had people with COPD or now with lung COVID that you have thought, oh my goodness, especially with COPD long before COVID, those people's skins would be so stiff. It's not only the lungs, it's their skin that is stiff. And that is often the whole organ zone that's stiff, not only those lungs in the middle of, on top of your thorax or under your thorax, but it's actually the skin that's also quite stiff. Right, now the original diaphragm tape, not the original by Kenzo Kaze, but because he normally did more what you see on the bottom right here. This gentleman more or less has a total diaphragm tape, as it was called, because you can imagine the diaphragm together with the vocal cord and pelvic floor are, of course, extreme important as pressure regulators. So for me as a physio and seeing so many children and adults with weakness in their trunk, one of the first things I go to is that diaphragm. So because your whole muscle chains can't even work if your transverse muscles are not strong enough. So that's one of my first choices. But the way I learned it was to apply tape in the middle and then turn the tape and go right to the back. And I changed that straight away, because if you start in the middle and you apply tape in that direction, the recoil will be in that direction. And you now understand, I don't want that. I want my recoil to the back. I want my recoil, my tape, to copy what my hands have already shown me. So these are examples of, so on the right, top right is a young man that I will start the taping from the back, still on top of the skin, on top of the diaphragm. So that can be quite high, going from the back and going to the front. Or the mini tapes, because I did develop mini tapes, because often we don't need the whole tape. It depends on your patient. And I love the spot, say, that you see with this young man in blue, because we also activate the obliques in that region. So these are the mini tape, the tapes, the official diaphragm tapes and the mini diaphragm tapes. But if you apply a tape and you start in the middle of the trunk or the stomach, and you pull the tension of the tape and it will go back to the midline, you don't understand skin. And that is, I think, one of the big problems with most of the taping courses. They have not taken skin into account enough. If you don't know what skin does, you are taping on skin. You are not taping on fascia or whatever you think you're taping on. You might be correcting a joint, but you're still doing it on skin, and only on the epidermis. So everything in the epidermis is important. Now, I want to show you a few examples. Now, I don't know if many of you have ever had a patient with these giant omphalocaris. Children are born with liver and parts of their intestines out of their body. It's quite a horrific disease. And this young man, I've been following him since his birth, and he's now 20. So it's been a fun time. And at the time, I was quite new to taping, so I was learning, but you can see how having a giant omphalocaris, which has been surgically corrected, influences the whole position of his breathing and his whole thorax. There is a bit of a scoliosis, as you can imagine. He's been pretty good because he's been very fanatic and has gone to the gym. So his rectus abdominis of these children is still there, but it's somewhere here. And sometimes it's really gone to the back. So these babies have their rectus abdominis, but it's not where it should be, and there's no linea alba. So when they correct, the surgeons try to bring that rectus abdominis back into more or less the position. But in his case, it was about 6-7 centimeters apart. But he trained and he trained and he trained, and he managed to get them together about 3 centimeters, say an inch apart, which is really good, because he worked that hard on his core. But I used tape on him, and one of the other things with tape is, and that's why I only recommend blue and beige, is that not every color is accepted by the body, but that's a different story. Right, so this is him breathing. Nog een keer. Wow. So you can imagine in time that's going to be really problematic. So I was trying to, and I have not taken enough videos. At the time when I just started learning how to use tape, I was not videoing up, taking pictures of anything. But in his case, because he was in Holland and I was living in Spain at the time, I would see him every time I was in Holland. And I didn't see him that often, but I would film because of that. So we do have these videos. But you can imagine this type of breathing, his diaphragm, it wasn't really possible for him to do that much. And he actually has his liver somewhere, not behind his ribs, but in his stomach wall. So the whole, it's quite a mix-up inside the bodies of these children. And so, yes, you can't expect the breathing to be completely normal. Well, this young lad, and I've been an advocate for using a lot less tape, but I must say the person that did this really made a mini tape. So if you look carefully on the right, that's a tape. That's a mini diaphragm, but it's more mini than I've ever done. So, but this is a speech language therapist who had done this course, and she was using this on a young lad who was in hospital after a pretty bad accident. So this is his breathing possibilities. and his strength and his endurance. Without that piece of tape, and this was with, straight away, as soon as you apply, you activate muscles and they can be used more. So it's a wonderful way of, using tape is a wonderful way of adding possibilities to the treatment you're already giving. Her treatment didn't change, but it made a big difference for him, and he enjoyed doing his exercises because he could see the results. That's the wonderful thing of our tapes. That's why a lot of people, that's the disturbing difference between people that still saying, oh, it's a placebo, it's all in the mind, and others saying it's magic. To many, this seems like magic, but it's just a question of giving the brain the right stimulus. You saw this slide before with the skin movement. Now, not every patient can be taped where I would like to tape them. So we have developed a few new taping applications, and we've called them the upper abdominal expansion tapes, for lack of a better word, because we use a lot of abbreviations because we realize we're not taping a muscle. And in most taping courses, you will learn to tape this joint, this ligament, that muscle. No, we're taping function. So in this case, the function is expanding my abdominal wall, and I can do that with 4 little tapes that all, I have to make sure that my base is as stable as possible, because your skin does not move the same everywhere. It is attached to deeper layers in many places, like every skin fold. So having that idea of giving stimulus to stretch the stomach wall is one option. And the other one, because the little dots are where we put our base, is what I let you experience before. Even if I'm pulling the stomach lower, I can't touch this because maybe there's still surgery wounds open here, but I can expand that stomach wall, and that will influence breathing. With these tiny little tapes, that will influence breathing as well. Right, now you can imagine that taping intercostals is really something that will definitely be effective for breathing as well. And the interesting thing is that I know that you are all into breathing, but thanks to breathing, we live, thanks to a muscle like the diaphragm, but also the intercostals, we have stability and the possibilities to be able to stand. And as a pediatric physio and working with neurological patients my whole life, adults as well, we're very interested in having a stable trunk as well, and breathing, of course. So in this case, a very short video of my colleague from Poland who tried the intercostals, only a few, just a few intercostals, we don't need them all. And you see the result on posture and gait. And that's after 5 days of intensives. A much more stable trunk. You can imagine her breathing will have changed as well, but she has much more strength in her trunk and now can hold her trunk in one position, which is what it's supposed to do. I want to show you this one because, yes, there's many more. You can imagine every muscle, for example, what's his name, the one that opens the nose, and there's lots of tapes you can buy to open up the nose to be able to breathe. I have been thinking, should I show you this one? Well, no, not really, because this is something that it's not the first tape I would be thinking about, and we have to go, make sure there's nothing wrong before we start opening up. But skin stretch in this direction will open up the nasal opening and help you breathe easier. But these correction tapes to the arms, the Bobaths did something like that. We learned to steer our patients with external rotation of the arms, and then your patient would be nice and upright, and they would start diaphragmal breathing. There's a research being done by a dentist who works with CPs a lot, and they looked at the position of the child in the chair, and we're talking really the cerebral palsy children, who are all, of course, in internal rotation, And they discovered that putting those arms in external rotation made a big difference for their work. So it's for dentists, it's easier to work if you can position your patient with external rotation or give them tape before they go to the dentist. So this little tape, so this is Thomas, and you'll be seeing him in a moment. I wrote an article about this type of tape, and he actually has quite a big one. Many of our tapes copy what our hands do. So if you have found a position, a skin stimulus, that you have noticed, hey, when I do that or I touch them in that way, it really works. Try applying tape doing exactly the same. And that's what we're seeing in the next video. If you get into the right spot, you can make a huge difference. And again, being a pediatric physio, that's been my work mostly for the last 20, 25 years, but I have seen both adults and children. They are the examples that I have the videos of. And I think for you, it'd be really interesting to think of those arms instead of always being busy with trunk and everything related to all the breathing muscles. So this is Thomas. He has cerebral palsy, and I've been following him as well since he was quite young. He is now a 19-year-old who's sadly just been in and out of hospital because of his breathing problems. But at this moment, he was trialing a second suit, and he was at. I was at their place to see if taping could help him with, and it wasn't breathing we were looking at. We were looking at because that is something that parents always want. Can my child walk? I want my child to walk. Now he's blind, so I have turned off the sound because I'm singing, and he's going to come and give me a kiss. At least that's what he's trying to do. You can see the second skin lying there on the sofa. He's trying to get to me. He is an extremely lovely young man, and he really is trying to get to me, but he can't. It's just too difficult without his suit on. So this is him in his suit. And it's still not really easy. There's still a lot of balance problems. And of course, we all have vision, and vision helps with balance. So he has to rely on what his feet are telling him for balance, what his trunk is telling, and the possibilities he has. So yes, with extra support, he is a lot better. And this was actually the first video we took. So the last we're going to have a look at in a minute is actually after he'd been walking up and down all these times, and so he was getting tired. So it was the least wonderful moment. So then I applied this tape, mimicking, and he had never had Bobath, so he did not know the Bobath handling. I just gave him the tape, giving him the impression that probably that he was being held, and look at that difference. I did get my kiss in this case. So 2 tiny bits of blue tape on his arms made him that much more stable because it activates extension and diaphragmal breathing. So he's activating the diaphragm and the extensors. And look at that. So you can imagine that I love putting tapes under a suit because then you have the extra effect. And see, without, he's still struggling. Oh, there he is again. Right. Now, I have no idea what the time is. I might be fast, but that doesn't matter because then we have more time for questions. So what I'd like to end by realize that you can't move if your skin is stuck. Think of your burn patients. If you've got excessive burns on your trunk, you can't breathe. You will have to use any sort of accessory muscle you have. You might end up using everything in the face and the neck to be able to breathe because your trunk can't move. Look for scars. Please start looking for more scars and treat them with tape. You can do that as well to see and test them with tape to see if it affects the breathing, because you might find it does.
This was fantastic. I really We have some people really complimenting everything that you're doing. So thank you, especially for the explanation about some of the more segmental breathing. Someone was saying that was incredibly helpful. I think you're absolutely right. We don't think about the external rotation quite as much. And that was, I am a little bit familiar with tape, so I don't know if everybody else is, but as many in this group are trained in orofacial myofunctional therapy. Some are dental hygienists, speech pathologists, occupational therapists. We also have some dentists as well. And some of the taping we're familiar with is taping on the face, particularly the mouth. So thinking about not necessarily the diaphragm, but also working on lip closure. Is that something? Is this
Yes,
so? Is
yeah.
the thinking behind that very different from taping in other parts of the body?
No, it's the same in the face, and the reason that together with the myologist that we worked together to make this tape work, because I had done this Bobath course and feeding, and the first time I saw an orbicularis oris tape, I was horrified because the example was actually of somebody with spasticity who had an open mouth. And of course, her whole jaw was misformed, so she couldn't really actually close her mouth properly. That was years ago. It was a presentation at a symposium as this is really good for, fantastic tape to close the mouth. But that didn't make sense to me. The orbicularis oris, I can swallow without using my orbicularis oris. I don't need it. I mean, it doesn't look that interesting, but it didn't make sense. And then knowing more about skin, this is a pretty sensitive area. A lot of mechanoreceptors and receptors here. Have you like tape being removed from your lip? I don't think so. No. And the thing is, the Castillo-Morales method has all these trigger points. Your speech language therapist should be familiar with Castillo-Morales. And he discovered that this point was a really important motor point. And later on, research showed that, yes, the sides of your lips, the end of your lips, that's where you have an enormous amount of mechanoreceptors per square centimeter. So there's many more receptors here than there are relatively here. So what Pam Marcella said, I completely agree with her. She wrote an article on her blog at the time, and I was in contact with her, but then she sadly passed because we were so in the same direction. You must remember, she wrote an article about kinesiotaping saying, we don't need this. All you need to do is 2 tiny strips on the side. Look her up, look that article, it's still online. I totally agree. And it's now, with the research we know, it's based on anatomy. It's based on, I prefer to close the mouth to either do 2 tiny strips a la the Marcella tape, the mouth tape, the end tape, or the S tape. Because a tape in the triangle, the submental triangle, which we started calling the S tape, activates swallow. So increases swallow frequency, even in healthy people. And it has shown it was developed to treat drooling, but speech language therapists that were using it were saying, oh, it actually helps for speech as well. We need a lot of muscles, including the tongue, for breathing. So if there is a low tone tongue, even maybe putting a tape here. So what speech language therapists in that case, I'm glad because Judy Macias and I have been in contact, and she is kinesio instructor, so trained in the original and the updated method. I'm the other model. So I'm much more of how can I use less tape? Check all the brands, because yes, no one brand is suited for every skin type. There are 6 skin types. Not every brand is suited. And in most taping courses, you only get to work with one tape brand because that's the company selling the courses. There are very few people doing courses that actually work with 5 or 6 brands like I do. And so I test them, and I let participants use all these different brands because not everybody tape's not suited for everyone. So when I look at the original ideas, how taping, and still being used a lot, the Kenzo Kaza ideas of I need to tape from origin to insertion. When you start doing that on the face, does not make sense to the brain. I last saw a picture of a poor young girl, a young boy, I think, with a ventilator, and they had given him orbicularis oris. They had covered his whole chin, God knows for what, and they'd given him tape in his. It was one blue, I would say, a brace, sort of an elastic brace. I think, what is? With a lot of tape, I ask myself, what is the information that we are sending to the brain? We're holding it so it's comforting. It'll give a feeling of support. We also know that tape influences pain. So if there's pain, great. But skin is so powerful. If you have wounds on the inside of your mouth and you put tape where the wound is, it will heal faster. They certainly heal faster anyway, but the pain will go. Brackets, tape on the outside, and the bracket pain will go. So we know that tape, applying tape, and there's research to prove this enough, it helps for pain. Great. Use more tape then on the bit that's hurting. But I would say the smaller the application and the more it is doing something that makes sense to the brain, the better the result.
That's what I've been finding, that less is more. Someone just mentioned they tried applying micropore tape on both sides of the lip, just like you mentioned, and she does feel the information and the input that she's getting to when she's opening her mouth. So
yeah,
for that.
Yeah, but the big difference between, yes, and that's great that people start trying this if you've got tape by hand. But the wonderful thing is with elastic tape, and you put it on, say, stretching the skin a little bit, but not the tape itself. You don't need to stretch. As a matter of fact, please don't stretch the tape in here. You can still open your mouth once you've rubbed it, not if you've just put it on and not rubbed, it'll come off. But if you've rubbed it like you need to activate the glue, then you should be able to open your mouth. So you can still open your mouth if you need to, but you don't want to. Your brain is telling you that you need to keep your mouth shut. So that is my preference compared to the Botteco taping. I've tried the Botteco tape on myself. The problem with the Botteco tape is it's one brand with one type of glue. So it will be suitable for a number of patients, but not for every skin type. Mine, the Botteco tape does not stick on me. And it's not because I don't like it. I was blank. I try every tape. I've tried everything on my body, but it wouldn't stay on. So I have to copy it, or even better, use a tiny bit. And what we have done with the orbicularis oris, and that again is backed by what the Castillo Morales method was already doing, because when I did my pilot, we had 2 Bobath instructors and 3 Castillo Morales instructors in the group. So we were actually making new tapes that first pilot. We ended up putting a tiny piece of tape here, a tiny piece of tape here. That's enough to help the orbicularis, to tell the orbicularis to work, to do its job. We don't need that.
Yeah. Okay. No, that's great, because I think that's still being taught by certain people, and you see it. So I appreciate that. Thank you. Yeah. There's one other question. I'd like to be respectful of your time. This is about forward. It says forward neck posture in the question, but I think we're talking about forward head posture. We see that a lot with many of our patients with the rounded kyphotic shoulders and the forward head posture. Is that something you address sometimes?
Yes, and it's also being researched extensively, and there's a really fantastic little story. Certainly, at least 3 studies have been conducted looking at forward head posture and then comparing the original tape ideas, as in decrease tension of the trapezius and activate this muscle, and the whole picture of using a number of tapes to position somebody properly, compared to a piece of tape that was applied only on the processus venosus of C7, T1, T2, or C7 to T3. They were compared to each other. So in the first study, we had forward head posture taping being compared to this. This was the placebo tape. Effect was that they both worked as well. Both worked just as well. So a second study was conducted doing something similar, and same effect. And now the people doing this were all from countries like Korea and Japan, who already know more about energy methods. And if you're on that method, you're talking energy, you're talking that you're on the conception meridian, but you're also talking on you are, because tape is neuromodulating. You are neuromodulating. In new, yeah, we're also interested in neuromodulating, but it's neuromodulating. So the third person, so this tape didn't have a name. We were actually calling it the placebo tape. So this application from C7 to T1 or 2 or 3 became the P tape. That's what we're calling it. The P tape is that application. And in the third study, that was actually the application that we're looking at. It's equally effective. You don't need to put somebody and correct their posture. Often it's enough to just apply a piece of tape on the spine and do that while the skin is stretched, again, thinking those cells, and without any stretch, so it doesn't matter which technique you use to apply, ligament or muscle, it depends on what's handy for you. Apply it on top and people will straighten out. And it actually not only works for that forward head, it works for the whole posture. It's not only that, people are activated, like the same feeling that you would get when you try this on yourself. And paper tape, of course, is not elastic, so it's micropore is not preferred, and the glue is more aggressive. So I don't like having that on my skin, and it doesn't come off; it stays on your skin afterwards. So please don't use that. But it's we are learning that less is more, and thankfully, research is slowly catching up. But that's kind of research that you don't always hear about.
Right. So, okay, so you're talking of, so why doesn't stretch matter on that area in particular?
Because I'm already stretching the skin. And if I apply tape, just tape as it is, or I do the 10% stretch, it's not aggressive for the skin, because so many people have used too much stretch on tape that there's actually now a dermatological condition since 2017 called dermatitis caused by kinesiotape.
Oh, really?
Yes.
Okay.
And that means we've been making mistakes. We've been using way too much stretch. I think with a lot of methods, including other methods with tape that goes in two directions, using too much stretch and means you get, even if you don't use any stretch on the anchors or on the ends, you're still stretching that skin. And that can cause blisters, and a lot of stretch can cause skin irritation. And of course, children are really instinctive. If I've done that once, they'll never want to be taped again. Yeah. So I like, and the idea that I would say, in principle, thinking skin is a stimulus. You don't think muscles or fascia or anything anymore. You think skin anatomy and physiology. You don't think what's under, because we're not taping under, we're taping on. And knowing that and trusting that your skin is an organ of communication, and it will actually tell you if you're wrong. So you have an idea, you're putting your tape on, you retest, is the effect good? Is it's not, you'll have to replace, change it a bit, try another one. And you can do that with the same strip 2 or 3 times. And then maybe the 4th time you've got the right spot. And that's the one you're going to tape.
Okay. Got it. Thank you. I'm coming up with a lot of questions. We could be here all day. I don't want to keep you.
Well, one thing I would like to say about that, because I know that a lot of we have seen that speech language therapists who have been working with tape are especially interested in the face. But guys, do the trunk first, please. Because if that trunk is not in order, and if everything in the trunk, as in related to movement, stability, breathing, is not functioning well, your speech won't be as good as it could be. And we see, I think because it's interesting and fun, and that taping in the face is something that they love doing. And of course, if you're a speech therapist, you're not always used to asking somebody to take some clothes off. And people that are working with Bobath and neurology think that's quite normal. But if you're a speech therapist, you're not really trained to, look at a naked top and or at least see some more skin. And I would say, and the speech language therapist I work with in my method also agrees, who's also a Bobath instructor. She says, no, please start looking at the breathing and the function of the trunk muscles first, because we all know we can't really function if your center is not what McGill calls stiff. You have to be able to have a stiff core to be able, and then breathe as well, to be able to function extremities and head. So we do need that core. And even if it's something that really only needs tape here, check for scars. Please check for scars in that area. Yeah. Even scars that patient thinks, oh, no, I had that when I was 10. No, check.
Okay, thank you. That's important. I really like the emphasis on function here, because I think that's something that we are very focused on, function. I know appearance obviously is important, especially scar tissue, but the emphasis on function, like that's the purpose of the taping, to improve the targeted function. So I'll make this the last question. Someone is asking if there are any books in English that we can read more about this on, or if it's more just articles that are available.
There's a few things happening. The book that I would suggest, if you really do a lot of taping, that is interesting to learn, to take, get into your clinic, there's actually two. One is the Neuromodulation of Diana Jacobs, to get to know your skin nerves.
Okay.
And play with them and realize that they overlap, and dermatome's not the same everywhere. So you might need to, that's one anatomy book I would think would be handy in every clinic. And then the skin taping book of Fukui, because he has actually put what he did in his research, he has sort of added that to his skin, to his method. So you see a taping method, he tapes muscles, for example, from origin to insertion, and then he adds 2 little strips after and on other sides of the pleat, because every muscle or every joint has a skin pleat, and so he goes across the skin pleat. But why he does that is also demonstrated in the pictures related to his study. So you can really learn much more about skin movement from his taping book, and you can get some of his taping ideas. I wrote a book, but I don't agree with everything anymore. I've learned so much in the meantime that I think I'm not selling it anymore. What I am doing is trying to get, I've written a lot of clinical notes, and I've got them all on Academia Edu, and I've got them nearly on ResearchGate, because not everybody can get into ResearchGate easily. I also have a Facebook page called ETT-HNO, as in Elastic Therapeutic Taping in Head and Neck and Orofacial Disorders. You can you can find that, and if you've done a taping course, there is a group, but that group is not very active, so I'm not doing much with that group anymore, in which I will say, talk about new studies, or I will discuss a study and think, or even ask the authors, could you please do it again and do this and that differently. I've written a lot of those clinical notes about using mini tapes. The S-tape has been studied quite extensively now. Thankfully, it's not in any guidelines yet, but it is. I wrote a case study in 2009, and the same year, a few months later, a Brazilian speech language therapist had the same idea, not to do the orbicularis oris, but tape here. And that article actually talked about 42 patients and her good results with excessive drooling because of it. So since 2009, we've been having case studies, and especially in Spanish and Portuguese, they've had a number of studies, and I have collected them all and put that into a paper that is also, or you can find it all, but I can I'll make a list of all the references of the studies and the papers, so that I'll send it to you, not tonight, but this weekend,
because I think you've
so that people can watch. And the other thing that I'm doing, and that is coming, maybe if people are from Canada, they might know the Embodia online learning platform, which is mostly for physios, but anyone can join. I'm starting to put all my knowledge there. So I now have, and it's probably open from Monday, I have my Elastic Therapeutic Taping in organ dysfunction. That's the first course. And there's one coming, Elastic Therapeutic Taping in head, neck, and orofacial disorders. So my course is going to be online.
That's wonderful. Where that brings me to my next question. Where can we find out more about the course offerings when you have more?
Well, that's the information I'll also put in that list, because
Okay.
and maybe at the moment that I have that course online, I can actually send you an email and and
Yes.
say hi, my course is there, because I'm not exactly young anymore, and I before COVID I traveled a lot. I've been to many countries, but I'm 74 now, and my hubby is 15 years older, so we're not traveling as much as we used to. So I thought I'd put it all on online courses, and it is possible. And for those who have already done a kinesiology KT taping course, there is a bit of theory that you need to know more about and learn more about before. And I've given you a little peek,
Yes. I
peek
think
into
it's
it.
an underutilized modality that at least it's something that I've been interested in. Something that's very light-handed, but I think it can be very helpful for a lot of our patients, because we are dealing with a lot of motor skills, but there's also, as we know, that sensory component, and many patients benefit from that to help us achieve those functional goals. So that would be
And the
wonderful.
wonderful thing is something like the S tape. Against, I mean, if that helps for drooling, we don't need Botox. We don't need a hello, and it's extremely cheap. For the S tape, one roll is normally enough for a year, because not everybody. Sometimes it's say relatively healthy patients, not a problem. There's just a motor problem that needs to be solved, and with exercise. But patients with a neurological disorder might need to use tape the rest of their lives, which is seen as a negative thing. That's the same with Botox. You put Botox in somebody, when it's gone, you need more. So it's no different, but it's extremely less expensive. One roll for a year. But
That's
then
a
you
great
do need good stuff for your patients, because you do want to make sure that you're not using a tape that is aggressive for their skin.
Right. Okay, that's another important consideration. Yes. Thank you. I'm sure you discussed that more in your course. So I look
Yeah.
forward to hearing more about that. That's fantastic. Thank you very much. We had some very keen and attuned listeners today who were really following along and asking some great questions. And we thank you for your time and the information you shared. Thank you. I know it's the evening for you, so I really appreciate you setting aside this time to speak to us. And it's been a pleasure getting to meet you.
Yes, it was nice to meet you too. And questions can also, if there are any questions, feel free to share my email address, because I don't mind getting questions, and because questions sometimes bring new tapes. Questions patients have asked me have often been the cause for developing a new tape. So I'm still doing that, and I do have a number of instructors teaching it now. So I'm still, studying and
That's
thinking up
right.
new stuff, because that's the wonderful thing of being a little older. You have more time for this stuff. You have time for reflection and studying, and
That's right.
that's
Hopefully we'll all get there one day and have a lot to reflect back on.
yes,
Would you be able to include your email address on the list that you
yes,
email us?
yes, yeah,
So we can all get in touch with you if needed. Okay, terrific.
yes.
Thank you
Okay,
very much. It's been a pleasure. Everybody, I hope you have a great weekend. Thank you for
thank
joining
you.
us. You're
Yes, you too, and thank you very much for having me.
Yes, my pleasure.